Radiology in Bangladesh and Planning of Intervention. May I now request Dr. Rashedul Kabir to come up to the dais and present the presentation, please. I think it will be much more interesting. And ladies and gentlemen, if you do have any queries, please write it down on the paper so that we can go for the discussion just after finishing the presentations.
Assalamu alaikum. Very good morning, respected teacher, dear my colleague and beloved student. Welcome to my presentation. Title of my presentation is Overview of Pediatric Cardiology in Bangladesh and Timing of Intervention. Pediatric cardiology deals with both congenital and acquired heart disease. The prevalence is 8 per thousand live birth in worldwide. One of the study conducted by Professor Nurna Fatuma, she found it is about 25 per thousand live birth. And another study conducted by DGHS in 2021 and found it is about 19 per thousand live birth. Among the congenital heart disease, 84% are cyanotic and rest of them are cyanotic congenital heart disease. Among the cyanotic congenital heart disease, atrial septal defect, ventricular septal defect and PD are more common. This is our beloved motherland. It has 17 million of people. Among them, 4 lakh children have been suffering from congenital heart disease. Every year, 40,000 people, 40,000 newborn was born with congenital heart disease. With this burden, we have only 53 pediatric cardiologists and 15 pediatric cardiac surgeons in all over the Bangladesh. So there are 15 key institutes where we can take the pediatric cardiac center in Bangladesh. Among them, National Heart Foundation is the pioneer. It is the only government level referral hospital where you can get both pediatric and pediatric cardiac surgery management. So what are the challenges and gaps of pediatric cardiac care in Bangladesh? Number one, shortage of pediatric cardiologists and pediatric cardiac surgeon. Limited pediatric cardiac center in long waiting list. In NICBD, you have to wait at least 6 months for any pediatric cardiac surgery. And lack of intensivist and limited neurosurgical facility. Expensive treatment cost and lack of awareness leading to late diagnosis. আমরা প্রায় বলি ওষুধ খাওয়াই যে ভালো হয়ে যাবে, আসলে এমন পর্যায়ে আসে তখন দেখি পালমোনারি হাইপারটেনশন ডেভেলপ আইসিএল হয়ে গেছে, তখন আর কিছু করার থাকে না। So how can you overcome the situation? Number one, expand human resource and training, increase production of FCPS MD in pediatric cardiology and incorporate fellowship program in national and international level. Number two, early detection and approved timing of intervention. How can you detect early of congenital heart disease? Number one, fetal echocardiography. By dedicated fetal echocardiography can detect 80 to 90% congenital heart disease. And dual method, pulse oximetry and oscillatory method, we can detect 94% congenital heart disease. And second is appropriate timing intervention. Appropriate timing intervention is crucial. Late intervention could result in morbidity and mortality. So now I will discuss few cases about the appropriate timing of intervention. Atrial septal defect, that means both in the atrial level. Atrial septal defect usually closed by 2 to 5 years of age. It is 4 type: HD primum, second nerve, sinus versus coronary sinus type. If it is all kind of atrial septal defect can be closed by surgery, but few cases of atrial second nerve and adequate rain we can close by device closure. Atrial septal defect more than 8 mm need to close. Less than 8 mm does not need to close. Only observation and eye prophylaxis. What is eye prophylaxis? Maintain good oral hygiene and give antibiotic before any dental procedure. Next is ventricular septal defect, that means hole in the ventricular level. And if it is ventricular septal defect less than 5 mm per millimeter square, no need to treatment, it's just follow up. That means eye prophylaxis, good mental oral hygiene and antibiotic before any dental procedure. and moderate VSD 5 to 10 millimeter per meter square. Asymptomatic patient easily closed by 2 to 5 years of age. A symptomatic patient with improved medical management usually surgery intervention at 1 to 2 years. And large VSD more than 10 millimeter per meter square. Symptomatic not controlled with medication closure as early as possible. If the symptomatic controlled with medication surgery at 6 months age. Ventricular septal defect usually 4 types: perimembranous ventricular septal defect, muscular ventricular septal defect, inlet ventricular septal, and outlet ventricular septal. All kind of ventricular septal defect can close with surgery, but muscular ventricular septal defect and few cases of perimembranous ventricular septal defect can be closed by device closure. But it is done by pediatric cardiology. Next is PDA. PDA means there is abnormal communication between the aorta and pulmonary artery. If it less than 1.5 millimeter without murmur, no need to treatment, just IV prophylaxis. That means maintain good oral hygiene and give antibiotic before any dental procedure. Small PD 1.5 millimeter to 3 millimeter need intervention 12 month to 18 month base. Moderate PD more than 3 millimeter to 5 millimeter intervention at 6 month to 12 month base. And large PD more than 5 millimeter intervention at 3 month base. All cases of PDA can be closed by surgically, that means surgical ligation. Most of the cases of PDA can close by device closure. It is the bread and butter of pediatric cardiology. Top, it is one of the cyanotic congenital heart disease. Main pathology is anticoronal deviation of the coronal septum, leads to ventricular septal defect, pulmonary stenosis, and ovarian aorta and right ventricular hypertrophy. If pulmonary artery is oil developed, saturation more than 80%, it is total correction surgery at 6 months to 12 months of age. If saturation less than 80% and pulmonary artery is not oil developed, initially surgery is shunt surgery. After shunt surgery, we give time for growth of pulmonary artery, then go for total correction. Now I discuss few cases that are routinely done in NICVD. Submit 3-month-old boy diagnosed a case of aortic stenosis. We plan for balloon aortic valvuloplasty. We send the patient to the cath lab and valve at the level of aortic valve, gradual inflation of the balloon, and disabling the OS, that means both effective ballooning and decrease pressure in the alveoli 50%. Next is pulmonary stenosis. 2.5-year-old boy diagnosed a case of severe pulmonary stenosis. We have planned for balloon pulmonary valvuloplasty. At first, wire in the left pulmonary artery and advance the balloon through the wire. We gradually inflating the balloon, that will decrease the oils of the balloon and decrease pressure of the RV more than 50%, that is effective of the balloon. My patient is 6-year-old boy diagnosed case of moderate ventricular septal defect. Plan for BSD device closure. At first, BSD device at the level of ventricular septal defect and positioning of the device by manipulation of the sheath, and graphy was done, that the dye is given to the LV, no dye is passing through the RV, that means balloon at the positioning, and rechecked by the echocardiography. Then we deploy the ventricular septal defect at the ventricular septal defect and remove the sheath. It will remain lifelong. And a 5-year-old boy diagnosed case of large ASD. HD device at the level of interstitial septum, positioning of the device by manipulating the sheath, and recheck it is positioned by the echocardiography, then removal of the sheath. Device remain at the level of interstitial septum. It will remain lifelong. Another patient, patent ductal arteriosus. The 1-year-old boy diagnosed with case of moderate size PDA. At first, dye is given in the aorta, visualization of the PDA, that is PDA and pulmonary artery. Then we deploy the PDA device in the PDA by manipulating of the sheath and giving check dye for the pulmonary artery, sorry, aorta. No dye is passing through the pulmonary artery. So the PDA PDA device block the PDA. My last case, 20 days old boy diagnosed with severe portion aorta, present with heart failure. This panel showing giving the dye to the aorta to identify the portion of the point, and then in this balloon at the level of the quadration, gradually inflate the balloon, remove the wire, keep this pressure of the ascending aorta and this pressure of the descending aorta, that is effective ballooning. All pediatric cardiologists should be patient skillful, that means physical and cognitive skill like that. But during the procedure, we do not underestimate any events of the procedure, otherwise casualty may develop. This is our whole team, grad unit. I am belong to CB4. She is CB10. She is working as a consultant in pediatrics department. Thank you very much.
Very much for being part of the presentations and to know how we can help our